Since Dr. Johann has to leave early, so there is a small change in the program. So first talk will be by Dr. Johann Christopher from Care Hospital, Hyderabad, and he is going to give a talk on the valve assessment, how the CMR is going to be useful as compared to the echocardiography. He's a cardiologist, so he's going to talk on the cardiac MRI. Over to you, Dr. Joe.
Thank you, chairpersons, and I bring greetings from the Indian Academy of Echocardiography. My president will be, Dr. Satish will be speaking next, and we have had a very fruitful, harmonious relationship with IACI. I myself an IACI member, and we've been collaborating in the past, and we hope to do so in future. And we have a major conference coming up in March in Mumbai, and all of you are invited. We will share the link soon. So, without wasting much time, in valvular heart disease, and it's a debate between echo and CMR. This is our imaging center at Hyderabad. It's interesting to see that the IACI guidelines in 2017 developed their guidelines in collaboration with the CMR. So you know how powerful cardiac MRI is politically also in the disease evaluation. When you look at the CMR versus echo, you can see that in the guidelines, it all starts with discrepancy between the findings on echo and the clinical assessment. As cardiologists, we see these patients, we look for murmurs, we look at their ECGs and echocardiograms, and when we find the discrepancy, we want to look at the third umpire. And since we're in the World Cup fever and today is a great match, I would say cardiac MRI is the third umpire right on top. He's certainly not the umpire on the ground, and that's transthoracic echo by a very far margin. And the class of recommendation again is high if you have the discrepancy. So this is just to set the tone of the talk so that we don't start doing CMRs for all our valvular heart disease. So this is our lab, and we do a large number of cardiac MR, and you can see that valvular heart disease is there, but it is certainly not as much as the ischemic heart disease, which is there in the light blue, and the cardiomyopathy. So that's where valvular heart disease is positioned in a cardiology-based center. And with all the flurry of treatment tools now that we have, cardiac MRI is slowly coming into prominence in the evaluation of these patients. And what does the MRI toolbox offer you? We have heard that from morning: function, volumes, scar, valvular stenosis, not so great, and definitely valvular regurgitation. And we have seen how MRI is a one-stop solution and covers a whole gamut of morphology, function, tissue metabolism compared to the competing techniques. The techniques I'm not going into because we've had these sessions from morning. Fairly simplistic. You need to have a good tech who does the job, who has the plan, who has the roadmap for you, and that's really important. And this is generally how I see CMR positioned in the evaluation of valvular heart disease. It's there, but it certainly is a small but important component. And this is what we do. We look at the anatomy, the pathophysiology, etiology. We talk about prognosis in these patients and associated anatomy. And this is really where the MRI really scores, and that's a big medal in favor of MR compared to echo in ejection fraction. And we know how fallacious ejection fraction is to start with, but to have a good baseline and to follow these up. Most of the valvular heart disease patients need to be followed up sequentially, and CMR is a great technique, and the inter-observer variation is extremely low, and all societies across the globe, the British, Canadian, and the American, vouch for that. And this is the standard ejection fraction assessment on the four-chamber view. We have heard that again in the morning, and you get very, very reasonable ejection fractions, even in a patient with a distorted anatomy and significant LV dysfunction. The data set is there. It's very clear. If you use your tools well, it becomes fairly inter-observer variant. So using the T1, T2, Vimal talked about it, and Dr. Ferrer also talked about in the morning. So amongst all the flurry of these diseases, the valvular heart disease has a small but important part when we look at the T1 and the extracellular volume, not more for diagnosis, but more for prognosis and whether these patients are right for surgical issues. Most important, however, is the fibrosis. And we know that having fibrosis adds that extra layer of a MACE in terms of all-cause cardiovascular mortality, sudden cardiac death, pushes us to send these patients for surgery earlier, and in some cases, we try to avoid surgery because of so much of fibrosis. And of course, every little bit of gadolinium is very important, and that really tells the story about the prognosis of these patients. The next technique that we look at obviously is flow quantification, chiefly across the aortic valve and the pulmonary valve, and we've seen that also today. So just quickly looking at some of the valve diseases, aortic stenosis, this is generally the data set that we would like to get out of the MR, and this is something that you've been hearing from morning. Valve planimetry, again, we don't do that usually, but remember to do it in systole, get a good section, and you need to have thin sections across the LVOT, and you get some very, very good planimetry images. Sometimes it can be challenging with the bicuspid aortic valve. And again, when you look at the technique compared to the established clinical techniques like echo and transesophageal echo, you will see in the most challenging valves, as you can see on the right, the MR really, really scores well, especially if it's a distorted calcified valve, the typical valve that you get when you want to do a TAVR and you can't do it because of the contrast limitation. So the valve planimetry becomes very important. You get a whole variety of variations in valve from mild, moderate, and severe. Planimetry is great across the LVOT. And of course, the new techniques coming in with 4D gives us a little more layer of information in terms of the wall stress, flow displacement, and also the kind of the track where the flow is going. And when you look at data between various comparing techniques, you can see that CMR scores very, very high. And again, the inter-observer variation is low, so you can repeat them again and again. It's non-invasive, and it's also no radiation. And compares very, very favorably with 3D echo and also the transesophageal echo, and much better than transthoracic echo. Always be careful when you're doing a phase contrast, especially in a stenotic patient, wherein the aliasing is a problem, so you need to choose your VEC images, VEC levels, VEC numbers carefully, otherwise you'll have a lot of aliasing and you'll have a lot of error in your report. So you need to have multiple VECs chosen, and then based on the aliasing, you can pick the VEC that goes with the degree of stenosis. So knowing the patient is very important. We call it a KYC of the patient. You need to have the ECG echo with you before you image these patients. Adding a layer of a non-contrast CT really helps, and you can map out the calcification. You can now score the calcification, and we know that in a male more than 2,000 and in a woman more than 1,300 as per the guidelines. These valves are likely to be significant, especially in a borderline situation. And this is a case of aortic stenosis. You can see the concentric hypertrophy we were talking about in the last lecture. You can see the very restricted valve motion here, and you can see the concentric hypertrophy, the volumetry, and the ejection fraction can be seen. And when you look at all the markers for severity, in this case, we actually gave contrast also because there was some doubt about a supra-aortic lesion, which was not there in this case. So gadolinium, looking at 4D flow, looking at the cine images, and also then looking at planimetry. So all these, when you add them up, you come with a very reasonable degree of stenosis. Moving on to regurgitation is where I think the technique really shines. That's the data set you want to pick up from your MR. And the important thing is the view of this place. So the LVOT view is a great view, and this is also where we look at the vena contracta. That's the pink arrow, because this is one of the parameters we take, because that's also a parameter that we take on the echo. So it's great for comparison. We look at the EROA also of the aortic valve, and anything more than 30 millimeters is severe aortic regurgitation. Flow quantification, again, very important, and we have those numbers. The American College of more than 60 mLs on the volume and also more than 50% on the RF. Very easy to do, straightforward. And some of the cases where the window is not good, patient is obese, or you don't see the LVOT very well, the echo can give you some very variable numbers, but here you just look at the VEC about a centimeter above the aortic valve and you get a nice clear regurgitant volume. Always look at the T1 in these patients, and the lack of diffuse fibrosis or normal T1 values again pushes these patients. We can get them, we can keep them on medical management compared to someone who has a little higher T1 with the same degree of AR. We know that fibrosis is setting in, and I think these are the guys who should reach the operating room. So again, looking at all the parameters of AR, the pan-diastolic reversal, you see that in the flow images. You've seen the LVOT view. Look at the vena contracta, anything more than 0.6. Look at the myocardium, no delayed enhancement. So these are patients that can be kept on medical follow-up compared to somebody who had a larger vena contracta, who had starting to have gadolinium or a high T1 values. And these are the numbers. These numbers are fairly similar to echo numbers. CMR data is a little limited, I would say. So we use a lot of the echo numbers and it works well for us. And of course, we look at the etiology. Generally, we look at valve versus aortic and aortic regurgitation. And you can see a typical rheumatic valve on the left. And these are the kind of patients we had in large numbers in the last decade when I started practice. Don't see them anymore, and we get to see more of infective endocarditis and aortic diseases. And you can see this is a patient with a failed flail aortic leaflet. And this is again a patient with an aortic disease with a significant aortic regurgitation. And this patient obviously needed a bent arm. Moving on to the mitral diseases, and again the data set very similar. This is the kind of data set you want to have as a checklist before you start imaging these patients. And again, very important in mitral regurgitation to look at all the three scallops, A1, A2, A3, and the P1 to 3, because you can have an isolated scallop disease, and these are great patients for repair where they don't need replacement and anticoagulation. So this is important information. Echo has a plethora of parameters to look at for mitral regurgitation. It's one of the most important and common things as cardiologists that we see. 3D echo has added another layer of benefit, but sometimes things can be very tricky. And if you look at the guidelines here, very busy, and sometimes you don't get those numbers of RV, RF, and VC. And that's when you go up to the third empire on the screen and you want to make sure this batsman is not getting out by mistake. And this is like a typical case, eccentric lesion, not sure, you're not able to map out this, the regurgitation area on the echo window, not great. And you can see here, you're seeing everything. More important, you're getting those numbers in. You're getting the LV stroke volume, 250 minus 100. That's the LV stroke volume, 150. Then you have the aortic flow, which is 80. Subtract that from the LV stroke volume, and you got the regurgitation volume of 70, which is important. And if you do the maths, you will get the regurgitation fraction. Very simple, takes about 10 minutes to do this. 47, this patient has a severe mitral regurgitation, no doubt about it. And that's generally the way we do it, especially in those cases where there's an element of doubt or there is a discrepancy. And these are again the numbers from the American College, and this is what we generally use. CMR numbers are similar. Again, we look for etiology, very important. I told you about the scallops. Mitral regurgitation is very common, especially prolapse is becoming more common. So repair is a very important part. Mitral stenosis with the regurgitation again is an issue. And obviously the ischemic component, as you can see in this patient had a triple vessel disease, significant mitral regurgitation, central jet, annular dilatation, and these are all LV factors rather than valve factors. We call it secondary MR. And this is an unusual case sent to me as a mass, we made the diagnosis of an LV thrombus. And what really helped us for the delayed enhancement, because we confirmed the presence of the thrombus on a TI of 600. And also you can see the delayed enhancement in the typical LAD territory, anterior septum and apex. So this patient had a silent infarction, was not thrombolized, was at home for about a month or two during COVID, and then presented significant mitral regurgitation because of the mass. The most important thing that we also look at when we send these patients for surgery is fibrosis. This is an important element that we add on when we talk to our surgeons. And obviously the consequences of mitral regurgitations, when they start becoming inoperable, they start having RV dysfunction. As you can see in this patient, MR is excellent for RV, and PAH also becomes a big problem. Mitral stenosis, not so great. Echo is really super for that. But again, use the data set. Sometimes difficult to image mitral valves, body habitus problems, calcified valve. Already patient had PBMV, OMV. So we do serial sections across the mitral valve, and we get these numbers, and we're able to do a very decent planimetry for these patients. Again, these are unusual patients, difficult to image patients. Always remember to do a stack of 4-chamber view, and you get all the valve facets. You get the typical doming of the AML and the PML fix, which is very, very common in our country as far as rheumatic heart disease. And you can look at the submitral apparatus, which is again important, whether to send them for a balloon-based therapy or for a surgical therapy. Right-sided diseases, I think, is where CMR really scores high. Again, you use the same data set. Here we're talking about the RV, talking about the RV dilatation, we're talking about atria. Very complex anatomy, so we don't even imagine imaging the tricuspid valve because it becomes very difficult. Echo does a much better job, and 3D echo is even better. But what we do look at is the RV function. The patient on the left with a tricuspid regurgitation with a normal RV function, prognosis completely different from the other patient on the right, who has an RV dysfunction. So again, the prognosis sort of changes, and the management also changes in these patients. Again, the same principle we use. We look at the RV stroke volume here, as you can see, and then we are looking at the forward volume through the pulmonary artery. You can see that also. And then when you put these two together, you get the regurgitant volume, 74 and 70% rejection fraction, which is very important. This patient needs a therapy for the valve in terms of a tricuspid valve reconstruction or a biprosthetic valve. Again, all the common etiologies, we can have a good look at them on the MR, and some unusual cases of restrictive cardiomyopathy with very severe tricuspid regurgitation, heart failure because of dilatation. We've talked about ARVD as well, and hopefully this will play. And you can see that the typical ARVD presence in this patient with all the microaneurysm and the dilatation. This is an interesting case of RV EMF, and Vimal showed that again, a hugely dilated area. There is a contraction of the apex. Moving on to pulmonary regurgitation, again, a very important disease, especially in the Guj population who have been operated about a decade previously, come to us for follow-up with heart failure. So again, pulmonary regurgitation, not the easiest to do on the 2D echo. On the left, you have a patient with a normal pulmonary valve, and there is no regurgitation. And on the right is a typical patient with a operated TOF, and you can see significant regurgitation. Very easy to do the planimetering well, take that area of WEG just above the pulmonary valve, and you can get these numbers very easily. It takes about 10 minutes. Very easy. We really struggle on the echo to do this, and many of these good survivors have had multiple surgeries. They are older, they are getting a little obese now, so the echo windows are really bad. And this is very important because we're now using a lot of percutaneous, we call them melody valves, which we're using on these good survivors. So we need to have very accurate RV volumes and also the pulmonary regurgitation fraction in order to then send them for the next therapy. So this is a typical patient of that. You can see the free PR. You can see the RVOT view. So MR is great for RV, all the views of RV, and I think Dr. Ferreira showed that in a last lecture. Without any problem, you get those views. And again, the phase contrast imaging, you get a very, very reasonable pulmonary regurgitation, which is as good or even better than what you can get on the transthoracic echo. And obviously, the consequences of the PR, you can see the RV is dilated, there is PAH, you get the fibrosis along the RVOT, RV free wall, and that tells you about the prognosis and possibly the inoperability of these patients. So ladies and gentlemen, certainly CMR is a great technique for the evaluation of valvular heart disease. It's by no means the primary technique to be used in evaluation of these patients. It's a great third empire. It's a great technique because it's non-invasive. There's no radiation. It's very friendly, and the tools that we use are very simple. You need to be good with your volumetry. You need to be good with your phase contrast imaging, and you get a lot of data. And it's a very great technique to be able to risk stratify these patients in terms of prognosis and also whether to send them for surgery or keep them on follow. And the addition of the T1 and T2 weighted images also help in picking up early fibrosis and sending these patients early. Thank you very much for your kind attention.
Thank you, Dr. Johann. So he has set the tone on echocardiography versus CMR, a big debate session. Before going to Johann, I want to ask Dr. Venisa regarding the different values what we are using in echocardiography. Can we use the same values for the cardiac MRI when you are assessing the regurgitation, like mild, moderate, and severe? The numbers what you are now having it for the echocardiography, which is people are using it for more than 4 or 5 decades, and the cardiac MRI, which is coming up, and but still there are no standardized numbers available for cardiac MRI. So you want to use the same numbers, or do you think that we have to use the different numbers for the cardiac MRI?
Yeah, that's a really good question, because I often have to just go online and look, and take a look. And you're right, the degree, what kind of cutoff. Sometimes, generally it's a good guide. I think, what you use in echo. I think there are some papers that, use CMR, to quantify those things. And sometimes we do end up just saying, if we can't decide it's on the borderline, it'd be mild to moderate, or moderate to severe, unless, it's quite clear it's mild or moderate or severe. But yeah, no, you're right. There are some degree of gray areas, in some cases.
Any queries from the audience? Okay. So since we are running late of time, so we'll move on to the next talk. So
please, can I please ask Dr. Vanessa to felicitate Dr. Johann?
So we'll move on to the next talk.